So some of the barriers and facilitators to exercise and physical activity. We're going to look and review some of the key terminology, explore the 7-factor model of factors affecting adherence to home exercise, and explore the theoretical framework of acceptability. So some generic barriers and some disease-specific barriers to exercise. So people may suggest lack of time, lack of motivation, poor weather, societal attitudes, so low levels of physical activity within the population in general, or disease-specific might be stiffness, fatigue, lack of knowledge or education around their condition, poor mobility and pain. Some of the facilitators, in terms of generic, might be social. It might be the fact that actually socially, it's well liked to be up and about and active, and they've got high levels of exercise for self-efficacy. In terms of disease specific, improvement during a treatment session or improvement in education might mean that they actually want to do more in terms of facilitate their exercise program. So as well as barriers and facilitators, think about coping strategies or ways in which people overcome barriers. So is pain associated with exercise engagement in rheumatoid arthritis, but the association disappears if we control it? Think about modifiers, so elements of context and health professional behaviours that might modify barriers and facilitators. And remember to think about where they are less likely to be barriers, where there are less likely to be barriers in your patient group. So how can you facilitate active participation in exercise rather than the barriers? So factors determining adherence to exercise. So home exercise adherence, looking at individual internal characteristics. So greater self-motivation, enjoyment of exercise, greater internal locus of control, greater coping ability and self-discipline and commitment, and lower fear avoidance behaviour. Individual knowledge and experience, so greater understanding of the condition, previous positive experience of physio or exercise, and previous good adherence behaviour. Social influences might include greater social obligations or uncomfortable environments, inappropriate equipment, inconvenient locations, exercise doesn't fit into the everyday routine of the patient, or presence of cultural barriers. Therapeutic relationships, so having that good patient therapist relationship, having a poor one can then impact poorly on the adherence of the patient. Lack of short and long-term goal setting or lack of active engagement in decision making and shared decision making. Unhelpful power dynamic between the therapist and the patient. Characteristics of treatment, so poor progression of exercise or poor understanding of what exercise means. Lack of bespoke programs for the patient, so not just printing out exercise and giving a sheet of exercises to a patient. Thinking about clear written instructions or using videos or drawings to be able to help your patient. Too many exercises and too long a duration of an exercise program, or greater complexity of exercises that then just alienates your patient. Effects of treatment, if there's no improvement or poor improvement, is the patient likely to continue to adhere? Worsening of pain during exercise, and then complete relief of pain. So if they have complete relief, they're more likely to stick to it or restart it. Support for exercises, poor social support or lack of supervision, lack of positive feedback. So you know what it's like when you're in the gym yourself and you get some nice positive reinforcement. Perhaps your patient's not getting that. Maybe they don't have clear instructions or they have a lack of regular follow-up. So acceptability is a multifaceted construct that reflects the extent to which people delivering or receiving a healthcare intervention consider it to be appropriate based on anticipated or experienced cognitive and emotional responses. So acceptability consists of 7 main domains: ethicality, intervention coherence, self-efficacy, effective attitude, burden, perceived effectiveness, and opportunity costs. So 3 of these domains can be assessed before a patient's even trial. So ethicality, which is the extent to which an intervention has a good fit to the patient's value system. Intervention coherence, the extent to which the participant understands the intervention and how it's going to work for them. And self-efficacy, the patient's confidence that they can perform the behaviour required to participate within the intervention. And we can use this concept of anticipated acceptability as part of our patient assessment and collaborative decision making. So health literacy, what is it? Does it matter? How does it affect health beliefs, and how does it affect our therapeutic relationship? So what is it? The personal characteristics and social resources needed for individuals and communities to access, understand and use health information. This implies that it's a critical empowerment strategy to increase people's control over their own health and their ability to seek out information and to take responsibility for themselves. So does it matter? Yes, it does matter. So recent research in England tells us that between 43 and 61% of English working age adults routinely do not understand health information. There's a huge human cost to this. The general reading age of the UK at the minute sits around age 8. So how are we going to educate everybody in relation to their health? So how does it affect health beliefs? So a lady who thought that her positive cancer diagnosis was a good thing and couldn't understand why she wasn't getting better. A lady who sprayed her inhaler on her neck because she had been told to spray it on her throat. Nobody had checked whether she realised she had to open her mouth and inhale. A gentleman referred under the 2-week cancer wait process who didn't turn up for his appointment because he didn't know the sign for radiology was the same as the X-ray department and he was too embarrassed to ask for directions. A group of young people who didn't know where their waste was. A lady with diabetes who didn't realise there was a connection between what she ate and her ability to self-manage her condition. And a lady who thought that her chemotherapy wouldn't do her very much good because her IV line was on the other side of the body to where her cancer had been. So how does it affect your therapeutic relationship? Is there a link between therapeutic relationship and patient education and health literacy? Aitchison suggests that there is, and that this is associated with health inequality. So this shows Sheffield by areas of least deprived, showed in green, through to most deprived, showed in red. This shows Sheffield by male life expectancy. So those in light orange or yellow have a life expectancy of between 80 to 83, and those in the darker orange have a life expectancy of between 75 and 77. And this is female life expectancy. So those that are really light show that they have a life expectancy of between 83 and 86, and those that are dark show a life expectancy of 77 to 81. If you consider where those darker aspects sit and the most deprived areas, there is a direct correlation in Sheffield between those that live in the most deprived areas and life expectancy. So, health belief. Make notes on the following types of model: the health belief model, the information motivation behavioural skills model, the self-efficacy model, and the theory of planned behaviour. The next few slides go through each model in detail. So thinking about the modifiable variables, perceived seriousness and perceived susceptibility, and talking about their likelihood of engaging in health promoting behaviour. Information motivation behavioural skills model thinks about the fluid motion between motivation and information, and then how behavioural skills implemented will then implement a behaviour change. Self-efficacy and beliefs, so performance experiences and observational learning directly feeds in with verbal persuasion and emotional arousal to then improve self-efficacy and belief. And the theory of planned behaviour. So this is a really complex model that talks about behavioural beliefs and attitudes towards the behaviour, linking in and being fluid with normative beliefs and subjective norm, and then feeding into controlled beliefs and perceived behavioural control, and then having a direct link to intention and behaviour change. What I would like you to do is go back over each of these and make notes on each individual one. So rehabilitation adherence, barriers and challenges to employing self-management strategies. Adherence with exercise is known to be problematic. Possible negative impacts of this would be increased wait times and healthcare cost, patient satisfaction suffering, therapeutic relationships being damaged, delayed healthcare, exacerbations in healthcare, and increased hospital admissions. So key messages are there's multiple determinants of non-adherence. It's highly complex. Changing exercise behaviour is hard. Physiotherapists said they're good at prescribing exercises, but they're not. Physiotherapists tend to blame non-adherent patients rather than looking at how they treat their patients. So complex intervention for a patient would be to look at the biological, biomechanical and neurophysiological aspects. Think about psychological and social impacts. Any organisational support for exercise or societal public health drivers that are out there. Thinking about individualised intervention and thinking about education for your patient. Challenges, so we've talked about these before, so societal, so thinking about decreased level of exercise and physical activity in general population. Think exercise and physical activity is easy and unskilled. And education is a reduced commitment to exercise on the academic curriculum about EPA and physical health, but it is making a comeback. It is coming back more into the forefront of education. And is your patient ready for a lifestyle change? So the trans-theoretical model of behavioural change assesses an individual's readiness to act on a new healthier behaviour, also known as stages of change model. So thinking about pre-contemplation or contemplation, preparation, action and maintenance. So they've got no intention to take action in the next 6 months. Contemplation, I'll intend to take action in the next 6 months. Preparation, intends to take action within the next 6 days. Action has changed overt behaviour for less than 6 months, and maintenance has changed overt behaviour for more than 6 months. What we're aiming for is action and maintenance stages for patients. It's widely recognised, however, that we cannot get a patient to change stages. That has to be facilitated. It's not that we can make an impact on a patient's changing from one stage to another. So rational choice theory. Simply put, what is the perceived cost versus the benefit of the patient? So staying the same. Do the negative costs outweigh the benefits? Do the benefits outweigh the negatives? What's going to make my patient change?